Hi everyone, your Optom coach this side, and today we'll be discussing the orbital connective tissue. The connective tissue of the orbit is arranged in a complex network that serves to line, cover and separate the orbital structures, to anchor soft tissue structures to the bone and to compartmentalize the areas. Although this network is continuous, the segments are described here individually according to their position and function. The first component that we'll be discussing is the periorbita, also known as orbital periosteum or orbital fascia. Now you have to remember that this is asked as a short note separately, so we'll be discussing it in detail. So periorbita is the periosteum lining of the surface of the orbital bones. It is supplied by sensory nerves and it is sensitive to pain. So now if you look here, the purple line is the periorbita, okay, here and here. This dense connective tissue membrane serves as an attachment site for muscles, tendons, ligaments and is a support structure for the blood supply to the orbital bones. It is attached only loosely to the underlying bone except at the orbital margin, the sutures and the edges of foramina and fissures. At the orbital margin, it becomes continuous with the periosteal coverings on the external surface of the skull and face. The line of fusion of these layers at the orbital rim is called arcus marginale and septum orbital is attached to it. A process is also given off to hold the trochlea for the superior oblique tendon in its position. At the edges of the superior orbital fissure, the optic canal and ethmoid canal, the periorbita is continuous with the periosteal layer of the dura mater. Okay. At the anterior portion of the optic canal, the periorbita splits such that one portion becomes continuous with the dura of the optic nerve, which is here, okay, and the other portion reflects forward to take part in formation of the common tendinous ring from which all the rectus muscles originate. Now at the apex of the orbit, the periorbita is thickened to form the common tendinous ring, also known as annulus of Zinn. At the inferior orbital fissure, the periorbita is continuous with the periosteum of the skull. At the posterior lacrimal crest, the periorbita splits into two layers, okay, which reunite at the anterior lacrimal crest. So at the posterior lacrimal crest it splits and at the anterior lacrimal crest it fuses again. These two layers enclose the lacrimal sac in the form of lacrimal fascia. The periorbita is continuous with the tissue lining the nasolacrimal canal, okay. Then another portion of the periorbita covers the lacrimal gland. The periorbita receives its sensory innervation, okay, from the branches of trigeminal nerve. This is an MCQ point and that lie within the orbital cavity. So coming to the applied anatomy of periorbita, during orbital exenteration, periorbita can be easily separated from the underlying bones except at the adhesions. Adhesions means the sutures, the foraminas where it is very well attached. A subperiosteal hematoma or abscess in the orbit has a convex lens-like shape. This is an MCQ point delimited by the sutural adhesions. The next component that we'll be discussing is the orbital septum, also known as the palpebral fascia or septum orbitale. Now at the orbital margins, the periorbita is continuous with the connective tissue sheet known as the orbital septum. So this is the periorbita, okay, which is covering the bones, and this green thing is the orbital septum, okay. It is circular and runs from the entire rim of the orbit to the tarsal plates, which are embedded in the eyelids. This is a strong barrier that helps prevent facial infections from entering the orbit. It also maintains orbital fat in its place. Now at the lateral margin, which is this side, it lies in front of the lateral palpebral ligament and the check ligament for the lateral rectus. So this is the lateral side, and it lies, the orbital septum lies in front of the lateral palpebral ligament and check ligament of the lateral rectus. At the superior orbital margin, it passes in front of the trochlea and bridges the supraorbital and supratrochlear notches. Okay. Now coming to the medial margin, it attaches behind the posterior lacrimal crest. It lies in front of the check ligament for the medial rectus muscle, which is here. Okay, the purple part. It lies behind the medial palpebral ligament. Now this is the medial palpebral ligament, okay, which has two limbs, anterior limb and a posterior limb, and Horner's muscle. This is the Horner's muscle. So now you can see the green part, this one, this is the orbital septum, which lies in front of check ligament of the medial rectus and behind the medial palpebral ligament and Horner's muscle. Also, and lacrimal gland sac, isolating the lacrimal sac from the orbit proper. Okay. Now coming to the clinical aspect of it, preseptal cellulitis is an inflammatory condition that affects the tissue of the eyelid. If an infection of an eyelid gland becomes more serious and involves the tissue around the gland, preseptal cellulitis occurs. This disease can be limited by the location of this orbital septum, which provides a barrier to prevent the spread of infection into the orbit, which could eventually result in development of orbital cellulitis. So, it plays a major role in limiting the infection. The next component that we will be discussing is the Tenon's capsule, also known as bulbar fascia or fascia bulbi. This can also be asked as a short note separately. So yeah, do pay attention. So Tenon's capsule is a sheet of dense connective tissue that encases the globe. Okay, so it enclases the eye globe. It envelops the globe from limbus to the optic nerve. So the Tenon capsule starts from here, encases the globe from limbus to the optic nerve, superiorly as well as inferiorly. It lies between the conjunctiva and episclera and merges with them anteriorly in the limbal area. Tenon's capsule is separated from the sclera by episcleral space, also known as Tenon's space, which can be readily injected. Its inner surface is well defined and lies in close contact with the sclera, to which it is connected by fine trabeculae. The lower part is thickened to form a sling or hammock on which the globe rests. This is called suspensory ligament of Lockwood. So this can be asked as an MCQ, that it is formed by the thickened lower part of the Tenon's capsule. Tenon's capsule is pierced by the optic nerve, vortex veins, ciliary vessels and nerves, and extraocular muscles. So at the muscle insertions, Tenon capsule forms sleeve-like sheath that cover the tendons. Posteriorly, around the distal end of the optic nerve, Tenon capsule merges with the dural sheath of the optic nerve. Okay, so this dense connective tissue capsule acts as a barrier to prevent spread of orbital infections to the globe. So this also plays a role in preventing the orbital infections into the globe. So the next component that we will be discussing is the suspensory ligament of Lockwood. Like I just told you, it is a hammock-like sheet of dense connective tissue that runs from its attachment on the lacrimal bone, that is posterior lacrimal crest at the medial orbital wall, to the zygomatic bone at the lateral wall, that is lateral orbital tubercle. Tissues from several structures contribute to its formation. This is an MCQ point, which involves thickened inferior part of Tenon's capsule, sheets of extraocular muscle, and inferior eyelid aponeurosis. Okay, it helps to support the globe, particularly in the absence of bones of the orbital floor. So this is the clinical aspect of it. The next component we are discussing is the orbital muscle of Muller's. It is a small, smooth muscle embedded in the periorbita and covering part of the inferior orbital fissure. So this covers the inferior orbital fissure. It is regarded as a vestigial muscle because its function is unknown. It receives its nerve supply from the sympathetic nerves. These are two MCQ points that you have to remember. So this is the Muller's muscle. Now the last component that we will be discussing is the orbital septal system. It is a complex web of interconnecting connective tissue septa which organize the orbital space surrounding the globe into radial compartments. Okay, so it is interconnected and it organizes the space around the globe into radial compartments. This system of elastic and collagenous tissue is well developed in adults. These septa pass inward from the periorbita to fascia bulbi, and they also connect the two and the intermuscular membranes. This connective tissue system of slings anchors and supports the extraocular muscles and blood vessels, attaching them to adjacent orbital walls. Okay, the slings associated with each of the muscle, the extraocular muscles, maintain correct positioning of the muscles during eye movement. We'll be discussing how the muscles, the sheets are connected to different muscles and how they help in extraocular movements in the extraocular muscle segment of the anatomy. Varying degree of connectivity occur throughout the orbit. That's it for this topic. For more such videos, do subscribe to my channel, and if in case you want any specific video, do let me know in the comments. Thank you.